So good afternoon. Thank you for the kind introduction. Just before I start, I'd like to say that I have no conflict of interest in this presentation, and that also we are using Sitagliptin as an off-label medication. So we know that type 1 diabetes is an autoimmune disease caused by an inflammatory beta cell destruction, which leads to insufficient insulin secretion. We also know that type 1 diabetic patients, they are varied and heterogeneous in their beta cell function loss and also in their disease speed of progression. Mainly because this beta cell function loss and the disease speed of progression depends on many variables such as age, sex, glycated hemoglobin, if the patient had or not ketoacidosis at the onset of the disease, and so on. So we also know that in the natural history of type 1 diabetes, we have this partial remission or the honeymoon phase, which is characterized by a decline for exogenous insulin need that starts shortly after initiation of insulin therapy in newly diagnosed individuals. In majority, the remission is partial, but in very rare cases, complete remission might occur. We also know that according to the DCCT study, preserving beta cell is very important for the diabetic patient, mainly because when you preserve beta cell, you have less clinical micro and macro vascular complications, long-term complications, and also you have less acute complications such as hypoglycemia and also diabetic ketoacidosis. So we also know that beta cell have GLP-1 and vitamin D receptors, which are important to function in the beta cell survival. Also, we know that Sitagliptin, a DPP-4 inhibitor, increases the intact GLP-1. And also, we know that DPP-4, also known as CD26, is a surface T-cell activation antigen. And we also know that DPP-4 inhibitors and vitamin D have immunomodulatory effects, and therefore we believe that this association may help in the treatment of autoimmune diabetes. So here, Marcelo Pinheiro and his colleagues have published an article where they have shown that Sitagliptin inhibits human lymphocytes proliferation and Th1 and Th17 differentiation in vitro, and he has shown that Sitagliptin does it in a dose-dependent manner, and that Sitagliptin may do it by decreasing the expression of CD26 on the lymphocyte membrane. Also, they have shown that Sitagliptin was able to decrease pro-inflammatory cytokines, and it was also able to increase anti-inflammatory cytokines. Here we have published another article postulating why do we think that this association may be helpful for treating autoimmune diabetes. So firstly, we know that both medications, they are able to reduce the immune aggression towards the beta cell, and secondly, both medications are able to protect the beta cell directly by avoiding its apoptosis and also by increasing the beta cell function. And here, in 2016, we have published a case report where we have showed that two type 1 diabetic patients, using this association, they were able to maintain their honeymoon phase for 5 years, and right now they are 80 years in the disease remission, and one of these patients, they are still insulin-free. So the aim of this presentation is to show a case series and to describe the frequency and duration of remission in new onset type 1 diabetics treated with Sitagliptin plus vitamin D3. So we have 19 patients with new onset of type 1 diabetes, male and female, treated off-label with Sitagliptin ranging from 50 to 100 milligrams per day, plus vitamin D3 ranging from 2,000 to 5,000 units per day. All patients or their parents signed a written consent term. So we collected retrospectively clinical data, fasting C-peptide levels, glycated hemoglobin, antibodies for diabetes, and vitamin D levels from our records. And here we considered that the disease was in remission when we reached insulin dose adjusted glycated hemoglobin lower or equal to 9. So the results, we have 10 male patients and 9 female patients with mean age of close to 15 years old mean time of type 1 diabetes diagnosis of 30 months and the body mass index of close to 20 kilograms per meter square. All patients had at least one positive antibody for type 1 diabetes. 6 patients had diabetic ketoacidosis at the onset of their disease. The final mean insulin doses was 0.35 units per kilogram per day. The final mean IDAA1C was equal to 8, and so close to 74% of the patients are still in remission with an average time of almost 24 months to reach this remission. 6 patients are still insulin-free with an average glycated hemoglobin of almost 6%. 15 patients had their glycated hemoglobin lower than 7% in their final evaluation. 2 patients had vitamin D3 deficiency and 9 had vitamin D3 insufficiency. And there were no major adverse effects, and the most common adverse effect was an upper airway tract infection complaint from the patients. Here we are showing you a graph where we show the time of the disease the patient has and also the time of remission of the patient. And when we calculated the median of this graph, the remission time was 16 months, and as far as you know, it's a little bit longer than when we compare to other studies or the natural history of the disease. And here you are just showing the average of the glycated hemoglobin at diagnosis and the mean glycated hemoglobin at their last evaluation. And here we are showing the fasting C-peptide at their diagnosis, and here we are showing the average. Both are the average, and here the average in their last evaluation. And here we are showing the vitamin D3 levels at their diagnosis from the 19 patients, and here the average from their last evaluation. And here we are just showing a data that we received from a mother of one of our patients. She is 6 years old, a female patient. She has been diagnosed with type 1 diabetes for 10 months. So she has been using this association for 10 months. And right now she is 8 months with the disease in remission. And she has been 3 months without insulin right now. And as you can see, this time range graphic shows that 97% of the time she was able to maintain her glucose blood levels on target. In conclusion, Sitagliptin plus vitamin D3 was safe and effective in prolonging the honeymoon phase in a heterogeneous type 1 diabetic population. The association of Sitagliptin plus vitamin D3 was able to maintain C-peptide measurable in all patients, even 8 years after diagnosis. The mean time of partial remission with this association was longer when compared to other studies. Complete remission without insulin occurred in 31% of our patients, and the first case with more than 8 years. Of course, this association in the hypertension treatment for autoimmune diabetes, although more studies are needed to prove this association, the function of this association, and also to prove the mechanism of action of Sitagliptin and also the vitamin D3. So thank you for your attention, and that's it.